Hello. Thank you for joining us. My name is Karen Becker. I'm the Clinical Director for Maternal Infant Care GE Healthcare. We're very excited today to be hosting this session and really appreciate your engagement. And we're very happy today to have an excellent speaker to deliver content for you. So I'd like to do a short introduction, and then I will turn it over to you. So Fátima Clemente is Senior Consultant Neonatologist at San Juan University Hospital in Porto, Portugal, a Level 3 neonatal intensive care unit. She has been the Director and NIDCAP trainer of the San Juan NIDCAP Training Center, Portugal, since 2015. Her main professional interests include infant neurobehavior and the development of strategies to integrate the NIDCAP conceptual model into the daily bedside practice across different NICU settings, organizational frameworks, and cultural contexts. She has served as the NIDCAP Federation International Board of Directors for the past 6 years and has chaired the planning subcommittee of the NIDCAP annual trainees meeting throughout this period. She has participated in numerous national and international conferences focusing on expanding access to NIDCAP education and implementation worldwide. Her efforts include developing and advancing NIDCAP Foundation education programs, creating innovative educational programs, creating innovative approaches to training delivery, and embracing new forms of online communication to broaden the reach and impact of NIDCAP care globally. Please welcome Dr. Fátima Clemente.
Thank you. Thank you, Karen, for your presentations. And it is with great pleasure that I accept the invitation from GE Healthcare on behalf of NIDCAP Federation International to participate in this symposium on the importance of neonatal unit environment in supporting the neurodevelopment, but also the sensorial development of hospitalized infants, as well as supporting their families. And I also so pleased to introduce you NIDCAP approach of care, a system-based, process-oriented, attuned, and responsive program of intervention and training for infants and their families, and that improves outcome. These are the disclosures that I mentioned. Every year, NIDCAP training centers from around the world come together to share experience and knowledge. Last month, just in September, around 200 participants from more than 30 countries gathered in Copenhagen, where the main topics was exactly the issue that we are going to speak, the importance of providing a supporting environment. And this is indeed essential when we talk about development and family-centered care for hospitalized children. This year, we had the privilege of including the ultra-early intervention conference on the last day of our meeting. And it was truly fascinating to bring together experts who share different interventions, strategies, all framed with the perspective of nurturing environments, supporting interactions, and development support care. Around the world, there are now more than 2,000 NIDCAP professionals, and we currently have 30 NIDCAP training centers, 5 in the States, 1 in Canada, 20 across Europe, 1 in Argentina, Israel, Australia, and Japan. And since 2011, the NIDCAP nursery program has recognized units that demonstrate excellence in the philosophy and practice of care for infants, for families, for staff and professionals, as well as their physical environment. To date, 8 nurseries around the world has been certified by the NIDCAP Federation International for this outstanding commitment. This quote from Professor Adelaide Halls, the founders of NIDCAP, beautifully summarized the sense of our work. It reminds us that safeguarding the quiet and soothing environment is fundamental for infants and family. It's how security and trust grow. To achieve this, we must first observe and see the newborn infant's strengths and sensitivities, understand the vital role of the family from the very beginning, and finally, implement the necessary system changes that must truly individualize developmental supportive care possible. This is the foundation of NIDCAP, a philosophy and a practice that transform neonatal care into a relationship-based, responsive system for infants, families, and professionals. These are the main learning objectives of this session. First, we will look at how sensory processing develops, understand how the brain receives, organizes, and responds to sensory input. Then we will explore typical sensory development, what happens in fetus and in preterms and in term babies. And then we'll discuss how the sensory environment of the NICU can impact the preterms, both positively and negatively. Because what is meant to be a healing space can sometimes be overstimulating or even stressful. Finally, we will focus on how we can transform the NICU sensory experience, creating environments that truly support infants' neurodevelopment and promote family and involvement and comfort. So, why does sensorial development matter? Sensorial development is absolutely essential for attachment and for the infant readiness to engage with the world. From the very beginning, the senses guide how infants connect, regulate, and learn from their environment. And these are critical periods during which each sensory system, touch, hearing, vision, smell, taste, proprioception, develops in the very specific sequences. When sensory stimulation occurs out of the phase, meaning at the wrong time or in the wrong way, it can actually interfere with normal brain development. That's why timing matters. When babies are exposed to certain environment experience is just as important as what they are exposed to. And this is a key concept in understanding how we design and manage the sensory environment in the neonatal care. And during fetal life, the baby brain is developing in a very specific sensory environment, one that is calm, rhythmic, and protective. This normal sensory experience shapes the neural structures of the brain, helping the fetus to build the foundations for later learning and behavior. And in utero, sensory development prepares the baby to adapt to and learn from the new world that will greet him after birth. When a baby is born at term, the brain is already organized in a way that allows him to interact with the environment in an integrate and coordinate manner. The full-term newborn can filter and process in sensory input, responding to the world around him and in an organized way. And the brain is never passive. It's constantly interacting with the environment. Every sensory experience triggers neuronal activities and contribute to shaping the structure of the developing brain. However, when the experiences are unexpected, intense, or stressful, their impact can be much greater and sometimes disruptive. This means that early development is a particularly vulnerable and critical period for the brain. The architecture of the brain is built through the ongoing interaction between genetics, environment, and experience, all influencing one another in a continuous dynamic process. And the sensory systems do not all develop at the same time. They follow a very precise sequence. The first system to develop is touch. It begins early in fetal life and provides a foundation for all later experience. Then come the vestibular system, which helps the baby with sense, movements, and balance. The chemiosensory system, responsive for taste and smell, develop next. Hearing matures later. And finally, vision is the last system to mature. And this table summarizes the sequence and time of sensory development during fetal life. As I said, the sense of touch appears first, as early as 7 weeks, and continues to mature through around 18 weeks. The chemiosensory system, which includes taste, develops around 12 to 14 weeks. Around 20 to 25 weeks, the vestibular and the kinesthetic system become active. The baby starts sensing movement and position, and this is still happen on the time that preterm babies can born and survive. Hearing develops next, between 24 and 35 weeks. The baby begins to perceive sounds. Finally, vision begins around 30 weeks, but continues maturing after birth up to about 2 years of age. And when we compare the intrauterine environment with the NICU environment, the differences are significant. In the womb, the baby lives in a warm, wet, smooth space. Everything is soft, elastic, and gently moving. The baby is surrounded by a dark red glow, constantly rocked by the mother's movements and immersed in gentle rhythmic sounds, mostly the mother head beating her beat and voice. In the other hand, the NICU environment is completely different. It's dry, filled with mechanical sounds. The surface is firm, the air can be cool or draughty, and the sounds often sudden and high pitch. Instead of slow motion and low gravity of the womb, the preterm infant experiences a static world dominated by gravity. These contrasts help us to understand how profoundly different the sensory experiences are for a baby born too soon. In the NICU, the sense of touch is often associated with discomfort, even pain. The preterm baby skin is extremely fragile and vulnerable. It is thin, sensitive, and easily injured. An average of preterm infants is exposed to a great number of painful procedures every day. For this baby, it is difficult to distinguish between painful and no painful touch. Both may trigger stress responses. The hands of caregivers are often cooler than the baby's skin, which can draw it away and cause discomfort. The baby also experiences a variety of tactile sensations, vibrations, temperature changes, handling, pressure, and pain, as well as contact with bedding, clothing, tapes, and tubes. So what should be a nurturing sense of touch can easily become a source of stress and sensory overload. And after understanding how stressful touch can be for a preterm infant, it's important to focus on what we can do to support positive sensory experience. Infants use their own touch and the touch of others to soothe and comfort themselves. The deliberate use of appropriate touch that is responsive to the infant's cue, level of maturity, and gestational age can provide infants with a positive touch experience, which can help promote self-regulation and neurological stability. Skin-to-skin care is one of the most powerful interventions. It provides warmth, stability, and above all, connection and improves outcomes. Gentle, loving touch, the touch that only parents' contact can do, help the baby associate touch with comfort rather than pain. We also give babies opportunity to grasping, holding, and support sucking that promote comfort and self-regulations. Touch should always be gentle, slow, and firm, not light or unpredictable. A soft mattress and bedding, as well as comfort clothing and wraps, can make a big difference in reducing stress. And maintaining the appropriate temperature and humidity in the environment help to create a sense of safety and comfort too. What about vestibular kinesthetic systems? They are responsible for movement and positions, and their beginnings developing quite early too. By around 40 weeks, sensory innervation is complete. By 21 weeks, the system is already functional. At 23, 24 weeks, we can observe a weak motor reflex that become a full motor response around the 30 weeks. At terms, when we see babies at terms, when the baby's body rotated and the eyes and head naturally turned in the same direction, showing mature coordination between movements and orientations. However, a preterm baby seen in the NICU is deprived of this continuous movement experience that occurs in utero. In utero, the baby is constantly rocked by the mother's breathing, heartbeating, and movements. In the incubator, that gentle vestibular stimulation is missing, and this can affect how the baby learns to regulate postures and movements. In the NICU, the vestibular system is often overstimulated in ways that are very different from what the baby would experience in utero. Sudden movements, quick transfers, abrupt position change, and frequently handling can easily overload the baby's immature system. For these babies, movement should be slow, predictable, contained, not chaotic and disorientating. In the first image, you can see a transfer to skin care done by the mother, who leans forward with her chest toward her baby, making the whole movement much more contained and gentler. Here, the ability to open the incubator, adjust the height, and bring the tray outward makes a tremendous difference in how the procedure of this transfer to skin feels for the baby. We can also see in the other image how activities such as bathing, waiting, or diaper change, when done with wrapping and support, can turn these moments into a much more appropriate and positive sensory experience for the infant. So we really need to ask ourselves, can we do better? Can we move and handle these babies in a way that protect and support their developing vestibular system, offering them a sense of safety, organization, rather than stress? The chemiosensory system, the taste and smell, begins to function quite early too in fetal life. By around 24 weeks, the fetus can already detect flavors in the amniotic fluids. At 28 to 29 weeks, start to react differently to sweet and sour tastes, showing early discrimination. At 34 weeks, there is already a clear preference for sweet flavors, something that continues after birth. At term, babies prefer flavors that are familiar from the amniotic fluid, and they can even recognize their mother milk by this unique smell. In the NICU, experience of taste and smell are completely different from what the baby would have in the utero. Many babies have their nose partially or completely obstructed by tubes or cannulas, which not only limits smell but can also cause irritation and even tissue damage. They are constantly exposed to chemical and disinfectant smells. The air they breathe is dry, pressurized, and the mouth often remains open and dry. Instead of pleasant family smells and tastes of the mother, what they experience is taste of formula, plastics, and medical products. In other words, the baby is deprived of the maternal odor and flavors that would normally provide comfort, familiarity, and a sense of safety. And after understand how disrupted the chemiosensory experience can be in the NICU, let's look at what we can do to support it in a more nurturing way. For taste, you can offer non-nutritive sucking with a pacifier dipped in breast milk. This provides both comfort and familiar flavors. We should always encourage breastfeeding whenever possible, and even when the baby cannot fed orally, breast milk can be used for gentle mouth care. is soothing and full of protective properties. For smell, having the mother sense close to the baby face can be deeply reassuring. Skin-to-skin contact is once again one of the most powerful ways to promote comfort and stability. We should also avoid masking natural maternal odors with perfumes or cosmetics, and be sure to dry our hands very well after using alcohol gel-based products to reduce the odor exposure of these babies. And here you can see some examples of how this recommendation came into practice. In this image, we see mothers holding their babies close in skin to skin, allowing the baby to experience both the sense of the mother and the taste of breast milk, even when oral feeding is not yet possible. Using a small drop of breast milk or a swab or a pacifier gives the baby that familiar taste, helping to create a positive association with feeding. Each of these moments, either during a feeding, either do a skin-to-skin care or gentle interaction, represent an opportunity to transform a medical environment into a nurturing sensory experience. These are small actions, but they have a profound impact on how the baby learns to connect, to regulate, and to feel secure. The sense of hearing develops also quite early and plays a major role in baby connection with outside world. By around 28 weeks, the baby can already distinguish between different voices, and it is most sensitive to low-frequency sounds, such as mother, her beating, and voice. At this stage, sleep is easily disrupted by subtle noise. By 34 weeks, the baby begins to recognize familiar sounds and through habituation start to ignore noises that were previously disturbing. At term, the baby already recognizes the mother's voice, her patterns, even the melody of her speech. And they respond to emotional tones of voice. They can tell the difference between a calm and tense, a soothing and a stressful tones of voice. Hearing is a very delicate sense, and for preterms it develops in an environment that is often far away from be quiet. According to the American Academy of Pediatrics, the recommended sound levels in the neonatal unit should be below 45 decibels for background noise and no peaks above 65. To give you a sense of what that means, a quiet bedroom at night is around 35. Normal conversation, 60 to 75. But in the NICU, alarms and monitors can easily excess 70 decibels. And when we drop an object in the incubator, the noise can reach 19 decibels or more. Even something as simple as opening a package can produce over 100 decibels. This is a value very close to the level where sound became painful. And this peak may be brief, but for a fragile preterm infant, they can cause startle reaction, sleep disruption, and stress response. The photos here are some examples of noise monitoring in my unit and an effort to make staff more aware of the sounds level that surround our babies. And reducing sounds and noise is not just about comfort. It's about protecting neurodevelopment and helping babies grow in an environment that supports healing and organization. When you think about the sounds a baby heard before birth, the contrast with the NICU environment couldn't be greater. In utero, sounds are middle range, rhythmic, predictable. The baby is surrounded by the mother's heartbeat, the sound of her voice, gentle rhythm of her digestive system. The sounds are filtered through fluid and tissue, creating and support auditory learning and help the baby begin to recognize mother voice long before birth. In contrast, in the NICU, the baby is exposed to high-pitched and mechanical and abrupt sounds, alarms, ventilators, sudden noise that have no meaning or patterns. Voice, when present, are often distorted or obscured by the equipment. So, The preterm infant moved from a multisensorial, nurturing soundscape to one that is fragmented and unpredictable. This change can interfere with the baby's ability to organize and process sensory information, highlighting the importance of creating, as much as possible, a more familiar, protective auditory environment. In this slide, you can clearly see the impact of noise in baby vital signs. There are visible change in heart rate, respiratory rate and pattern, and in oxygen saturation levels. And this reaction in this work, it's quite old work, is not from an extreme fragile or micro-premature baby. It's from a late preterm baby, one we might consider more stable and less vulnerable. In this more recent study, environment noise was recorded in different NICU's rooms at various times of the day, both at patient bedside and inside incubators. And it was clear from the data is that the record environment noise was always above 45 decibels, regardless of the room time, the time of the day. The analysis also show a significant physiologic impact. For every 1 decibel increase, there was a 6.6% increase on the odds of tachycardia. Noise levels also has also a measurable effects on the respiratory rates, confirming that sound in the NICU is not just about an environmental issue, it's a clinical factor that directly affects baby stability. We have seen how noise can affect the baby physiology, but its clinical implications go even further. Excessive noise in the NICU can cause autonomic instability, motor disorganization, and sleep disruption. It also distracts the baby during feeding or social interactions, and over time may contribute to language delays or even hearing damage. The noise environments also affect bonding. Baby must struggle to recognize their mother's voice in a soundscape dominated by alarms and mechanical noise. So maintaining a quiet environment is not simply a comfort measure, it's a core element of neuroprotective care. And these are several practice strategies to help achieve this. Avoid typing, writing on incubators, close the porthole gently, encourage quiet conversations, as we call library voice. Move ward rounds away from the bedside whenever possible, or at least be mindful of volume. Silence alarm promptly, and set tones and limits appropriately. Choose equipment with low noise specifications. And finally, monitor noise levels periodically so you can identify where you can do better. And this small change can make a big difference. This is exactly what you can see in this picture. Here, sound levels were monitored in 3 moments before any intervention, then after technical adjustments, and then finally after staff training and awareness sessions about noise. And the results are quite clear. The most significant improvement happened when we intervene not only on the technical aspect, but also on the staff behavior. When caregivers become more aware of the sound, environment, and consciously adapt their reaction, the impact is much greater and more sustainable. Here you can see some examples of intervention used in different units, and the strongest, most meaningful of this intervention is without adapt the parent's voice. The sound of parent's voice speaking, reading, or singing is something the baby already knows from the utero. Studies have shown that parental speech and singing have measurable benefits. They help regulate the baby heart rate, the breathing, improve oxygenation, support feedings. But beyond the physiological effects, it's also about connecting and bonding. Hearing the parent's voice helps the baby feel safe and recognized. It gives a continuity to their system world. So offering opportunities for this moment to happen should not be an occasional event. It should be part of every baby's care plan in the NICU. What about music? When you talk about music in the NICU, we need to ask some important questions. It is really music, or it's just more noise for the baby, especially on an open bay NICU? Recording music, on the other hand, can be difficult to control. The volume, the type of sound, and even the duration can easily become overstimulating, especially for very preterm infants. Research shows that music intervention may be suitable for older and more stable babies when they are ready to process and more complex auditory inputs. And we also know that some instruments and rhythms, such simple melodies or live music respecting the baby cues and following them, are much more appropriate. In this short video, we can see an example shared during a Fine2 courses. It was one of my trainees, and she is currently doing her PhD research on the use of music in Lisbon. I think you cannot hear. And we have a lot of discussions about it. And she changed a lot of her project because it's an open bay unit. And you can, when you heard this record, you can hear so many noise in the background. So even if the mother is involved, and sometimes you can see some connection with the baby and you follow the behavior of the baby, it's a very difficult intervention. And we must be sure when we do it with some babies. And vision. Vision is the less mature sense at terms, and it develops less. The baby visual system is designed to mature in an environment near darkness. The gentle environment allows for important periods of sleep, REM sleep, which are essential for visual development and brain organization. Sometimes my nurse says, because they are very concerned about light and input to the baby, and I said to her, if you want to protect vision, protect sleep, let baby sleep. Because we know that some processes during REM sleep are essential for visual development and brain organization. And when babies are born prematurely, they are suddenly exposed to an intense visual world that their brain are not yet ready to process. And this development begins later and continues after birth. At 24 weeks, so after the time that we can, this baby can survive and be with us in our NICU settled, the baby is sensitive to light. The eyelids are very thin and allow light coming in. By 32 weeks, we start to see short, brief gaze. The baby may turn the eyes toward the face or a soft object in the low light environment. The pupils begin to constrict, and the eyes may move in response to sound. By 34 weeks, vision becomes more coordinated. Baby can fix and follow a slow-moving object and face. A term is different. Baby can perceive forms and patterns. They can follow movements in different directions, horizontally, vertically, in an arc. And they're beginning to recognize their mother's face. And these progressions help us to understand why lighting conditions and visual stimulation in the NICU need to be gentle and well adapted to the baby's stage. Current evidence supports the use of low-intensity cycle lighting. Light should always be adjusted to the baby needs and cues, while also allowing staff to provide safe and effective care. Too much light can lead to sleep deprivation and disrupt sleep patterns. It is recommended NICU lighting be adjustable across a range of intensities, and the infants experience day and night variations. This helps babies develop a day-night rhythm, supporting normal cycle of hormone release and body temperature regulation. Ideally, light should be adjustable between 10 and maximum, I put here 600. I think it's a little too much. But how much light? What could you recommend? And this is still a little bit controversial. But we can do some adjustment in our unit. Use individualized lighting, and only when necessary. Adjust light levels with each nursery areas, and use focus lights for procedure or close observation. Monitor overall light regularly. And shield infants from bright light using covers, eyes protection, or dimmed lights. And keep general light level low, but safe for clinical care. And whenever possible, make use of natural light. Some example on this picture. Keep ambient light levels individualized. Of course, it's easier to achieve this with the family rooms, but it's not impossible to do it in an open bay areas. Use think incubators, covers, and reduce light exposure when needed. So, how can we tell, now that we have talked a little bit about the sense, how can we tell if a stimulus is appropriate and supportive for the baby development and experience? Development care is all about this, creating an environment that minimizes stress and offers experiences that are appropriate for the infant stage of development and for their family, with intervention that support behavior organization, promote physiological stability, protect sleep, encourage growth and development, and always individualized to each baby. On the NIDCAP observations, we look at how the baby responds through his 5 systems from a synaptic theory perspective. We look at autonomic signs, motor tone, posture, movement, state organization, attention, interaction, and self-regulation. And when we observe how this behavior changes in response to a stimulus, either the baby relaxes and engages or becomes stressed and disorganized, that tell us if the experience is supportive or too demanding. And this cue-based care, responding to the baby's own signals and adjusting our action, handling lights, sounds, and timing of care accordingly. And finally, none of this work without parents. Their parents' presence and involvement are essential to the baby well-being. Key messages from these last minutes. Sensory development in premature infants is profoundly influenced by both biological immaturity and the environment factor. And when a baby is born prematurely, their sensory systems, auditory, visual, tactile, are not yet fully developed. This makes them particularly sensitive to the stimuli that encounter in our NICUs. The environment of a neonatal intensive care, while medically essential, often introduce disruptive elements such as artificial light, mechanical sounds, and frequent handling, which can hinder development. Research increasingly emphasizes the importance of adapting these environments to support, rather than overwhelm systems, the sensory capacity of these vulnerable infants. The NIDCAP model switched the focus towards a more humanized, responsive form of care. It's an intervention and an educational program that uses developmental observations for multidisciplinary healthcare professionals who care high-risk infants and their families, and considers the baby as an active participant of his own development trajectory, relying on internal co-regulatory process and on his relationship with the parents, and supports the reorganization and co-regulation of the baby and their family based on understanding how each baby's individual needs. It actively involves parents in the caregiving process, recognize them as essential to their baby development, and lays the foundation for understanding how combining medical care with development and family support leads to improved outcomes. And require knowledge. of the foundation of neurodevelopment based on the synaptic theory, as well of the parents and family, and demands multidisciplinary collaborations and coordinations with organizational and institutional structure of the NICU and even of the hospital itself. This slide shows the NICU, the NIDCAP nursery program developed by the NIDCAP Federation International. This program supports and recognizes hospitals that are truly committed to integrate NIDCAP principles into everyday practice for infants, for family, and for professionals who care for them. The model illustrates the process of change from conventional care toward the highly attuned developmental supportive care. It begins with a clear philosophy and implementation care followed by assessment, reflection, and action, and is supported by education, mentorship, and team collaboration. This goal is a nursery culture where every caregiver, every decision, every environment reflects the baby's and the family perspective. These are some images for my unit in Porto. We are a NIDCAP training center, but not a certified NIDCAP nursery. And what you can see here are moments of supportive care and interaction. Parents provide skin-to-skin care, a few drops of breast milk putting in the baby mouth. Siblings include as part of the family, sharing gentle and meaningful moments with their brothers and sisters, and relationship-based care between professional families. And these moments represent the sense of NIDCAP approach of care that respect the baby as a person and the family as true partner in the care. But we also know there is still a long journey ahead to ensure this level of care happen constantly, 24 hours a day, 7 days a week, and across all our multidisciplinary team. We can see another example of caregiver moments with a potential pain procedure, the mother supporting and co-regulating the baby in a calm, nurturing environment. An example of connection between baby, mother, and professionals working together in synchrony in a safety and comfort environment. And we are not only referring preterm infants. In our unit in Porto, we also care for infants with cardiac conditions and post-surgical babies, where all these NIDCAP concepts of care are equally important and true fundamental to their recovery and neurodevelopment outcomes. In the first image, you can see how a single family room and modern incubators that allowed us to move the top of the incubators and rotate the baby with adjustable environment settings made it possible to perform surgical procedures without moving the baby. In this case, the thorax surgery teams is closing a chest of an infant around 48 hours after an open heart surgery. In these two other images, you can observe a supporting environment with parents present and involved in their baby's care. And to finish, I like to end with this beautiful quote from Professor Adelaide Halls. We are all connected. We are mutually support, teach, learn from, and enrich one another. And this truly captured the essence of NIDCAP, a philosophy built on connection, reflection, and support for infants, for families, and for all of us who care for them. Thank you. I don't know if there is any questions or any message. Yes, Nick.
Thank you, Fátima, for such a lovely talk. When you were talking about the music, you showed a short video clip
Yes.
And I might not have understood. I don't know what I was looking at.
Yes, because we didn't hear the sound. It was, she used like an harp, and then the mother sings, and we try, and I work with that because they must respond and follow the baby, and I think for these babies it's a little too much. And but it was in the Fine 2 courses, and my training, she really developed some skills that she didn't have before, and she begins to see the baby and see that some interventions are not point from the right direction that she should have on their project. So it was a very nice knowledge that she beginning. The Fine course, I don't know if you know, it's about foundation of NIDCAP. So we have different levels. The Fine 2 course is the beginnings to see for several weeks and months to see the behavior of the baby. And he opened their eyes to my
Okay, that was the reaction to the
Yes.
music. Because if I, as a developmental specialist, would advise this scene, I would rather have had the more supportive motor system.
The baby's a little bit
And
lost.
because the
in
baby
equation.
lies there
Yes.
like a frog, and you can sing all you want.
But when she, because it is in the session that they show me videos and we discuss the behavior of the baby, and she was delighted that the baby opened eyes during the music and lost all the behavior of the baby.
So there
that
was
are falling
overstimulation.
apart. Yes, yes,
Yeah, too much stimulation.
yes.
Okay.
Other questions? What did your unit find the most challenging for implementing NIDCAP? Was there one thing that was hardest, and how'd you overcome it?
It's a difficult question.
Yeah.
First, I think we are in this process, I think for 2 decades, isn't it, Nick? We began with Nick Cutman. 15 years, yes. So, and we learned some lessons from this journey. And it is important that all the staff speak the same language and understand the same concepts, basic concepts. If you try to build the building from the top, sometimes it doesn't work. And we learned that. So now we do basic training to all the staff, and we include all the doctors, nurses, head nurse, psychologic therapists on the same level of knowledge. And then, of course, there are some people that lead a little bit the process. But I think the most challenge is to include all the team on the project. And without this, things doesn't work. And let me mention, because we have done for these past 4 years a lot of work in Portugal, and the importance of have the parents involved in the process. And I have here someone from the Portuguese Parents Association that have a financial support on this training. It was crucial. And even to pressure the units to have people on this course, because if one unit have this training person, the other wants to. So it was quite a lot of, we had hundreds and hundreds of people on these basic courses, and thank you for your collaboration to Parents Association. Yes.
Thank you, Fatima, for the lovely talk. My question was very specific to our unit. So coming to very specific to our environment, coming to music therapy on the unit, or any form of music that babies get exposed to, or sounds, a lot of our parents, they leave like Quran running by the bedside. Now, we want to be as culturally sensitive as we can, and what is best for the baby and for the families, and to individualize the care based on cultural perspectives. But in terms of advising them, it's very difficult for us to tell them it's overstimulating or understimulating, or is it the right thing to do. So at the moment, we're keeping quiet. We just tell them to reduce the volume, and when the baby is asleep, we switch off. But what would your advice be on helping us in what we can tell parents when it comes to
I know that you present a communication early in the morning about it. I think the key point is involve the parents in the care very early, ultra early, as Tina said, ultra early. Because if the parents knows the cues of the baby, it's something that is natural. And of course, we ask, now we have some private rooms for in intensive care, but not in the other part of the unit. And sometimes to ask parents to sing or to talk to the baby is a little bit difficult. People are surrounded by a lot of persons. And reading it's a instrument that we can use, adapting the reading to the baby, and see the cues of the baby. But I think this is how partnership with parents on cares and parents beginnings to know what to do during this sensory inputs.
So basically observe what the baby does and depending to that.
Yes, we
then
try
decide.
to them to involve and we all ask special nurse because they are more side by side the babies to translate the language of the baby when they are caring with the parents and look at the baby and look at the reaction of the baby and speak louder to the parents to see the baby with the parents.
Hello, my name is Zuzana, and I'm from Czech Republic, and I'm actually specialized for the developmental care in Czech Republic. And to be honest, I worked 8 years in Saudi Arabia, and because we had a problem with the parents to stay there for a long time, and then the Quran was one of the things which was actually working amazing. So for me, the thing, as what you said, that to observe the baby, whether the baby is okay with that and what signs the baby is showing. But if you choose the correct sound of the Quran, it works amazing way. So it can calm the baby down. So I would just keep it. It's okay. Just observe the babies, and it's amazing.
And use what you have.
What specific behavior are you looking for? Because calming can also be perceived as overwhelmed and just,
Like the baby on the picture. Yes.
It depends on the gestational age, depends whether the baby is sick or not.
It does not depend on gestational age. It depends on the environment and all the experience that the baby has and had in the past. You cannot look at the calendar and say, oh, 34 weeks, then we can do this
But
and
you
that.
have to combine all the things, and you have to observe the baby, how the baby behaves, right?
But the interpretation of behavior is something that needs to be taught. And when the baby goes like that, some people say, oh, he's waving at you.
Yeah, I know.
So I'm very allergic, that's my reaction.
Sorry?
So, oh, observe the baby, what are you looking at? And I don't think, when you overstimulate the baby with Quran or with Christian or with any other mechanical sounds, because that's what I oppose most, that this sound should not be mechanical. It should be made by another human being.
But Quran is made by the human being.
Yeah, but it's recorded. If the father sings the Quran to the baby, that would be perfect.
Okay. So what are you going to do if the parents are not coming for 2 weeks?
Ask them how we can support them to come. And then we can ask a volunteer or a third person or a fourth person to support the baby while the parents cannot be there. I mean, like Fátima says, you have to build a relationship with the parents. I've worked in Saudi Arabia as a NICAP consultant, and I know it is a cultural barrier. But, you have to do well by the baby. And the parents, you want to make them understand, which is difficult.
I know, but that's the thing. Like sometimes you have to choose the best possible way.
I would rather choose an orderly or a nurse's aide to sit with the baby during the day for certain
Me
periods.
too, but if you don't have them, what are you going to do? So it's like, about the situation, what you have. So, like, also I have a different situation in Czech Republic because I have the parents. So for me, it's quite easy to do so, but there are countries where, like, you struggle with that. So I always think that if you do at least something, it's better than to do nothing and leave the baby there without anything.
Thank you. Any other questions? All right. Well, thank you for your attention. Thank you for a
you,
wonderful
Karen.
presentation.